So, coming up next is Miss Jill Smith. Miss Jill Smith is from the University of South Florida Health Byrd Alzheimer's Institute. Okay, close. I'm going to get it before the end of the day. Seriously, though, here's Jill. She has some great stuff to talk to you about clinical trials. Please give your attention to her and a big warm welcome. Thank you.
Hi, good afternoon, everyone. It's a pleasure to be here today. I was going to be talking before lunch, and we finished a little early, so now I have the task of keeping you awake after lunch. So I am Jill Smith. I'm from the USF Health Byrd Alzheimer's Institute. Sean, please take note. And I oversee all the clinical research studies that we're doing there. My background is in aging studies and gerontology, and I've been doing Alzheimer's research for the last 9 years or so. So this is a very exciting time. There's lots of advances, and I'd like to share some of that with you today. If I could have the first slide, please. Next slide. Okay. So I want to start by saying, first and foremost, Alzheimer's disease is characterized by memory loss, which I'm sure many of you know. And this memory loss occurs because the Alzheimer's affects a part of the brain called the hippocampus, and that's the part of your brain deep inside of it that makes all of your new memories. But in addition to that, it also affects your brain cells' ability to communicate with one another. So before I talk about the research medications, I want to touch base a little bit on medications that are currently out there. I know a lot of people go to their primary care doctors and they receive these new medications, but they're not very well educated about the goals of the medications, what they can and can't do, so the real expectations are a bit unrealistic. So I hope you walk away with a little information about that as well today. So basically, to help you understand this concept, if you imagine all of the brain cells in your brain are a very large baseball team, and there are lots of players. Alzheimer's affects that team as if you're tying one of their hands behind their back. They could still probably play the game, but they're going to miss the ball every once in a while. And for an Alzheimer's patient, missing the ball is like missing that signal or missing that message. And how that might come to play is they're trying to remember something. And so as you try to remember something, you might think of who was there when you were in that event, where were you, what time of day or what time of year it was. And so that ball is getting missed, and so there's pieces of that communication that are dropped, and then how that presents as Alzheimer's disease is somebody may not be able to remember something. So there are some currently FDA-approved medications that Alzheimer's patients can be on. The first class is cholinesterase inhibitors. These are known as rivastigmine, donepezil, and galantamine. You might know them as Aricept, Razidine, and Exelon. These essentially are medications that try to help the breakdown of a chemical called acetylcholine in your brain. Acetylcholine is a chemical that's trying to help those players on that baseball team work better together so that messages can be sent and so forth. But there's another chemical that comes along and tries to break that down. So the cholinesterase inhibitors are trying to help that particular chemical in your brain. An Alzheimer's patient should take one of these. I've heard stories of people who've come to me and their primary care doctor, who's not very knowledgeable about these treatments, they're on all three, and that's a horrific incident. So you make sure you know only one. In addition to these medications, you can also take another FDA-approved medication, memetine, also called Namenda. This also helps the chemicals in your brain send messages back and forth, but this particular one works on another chemical called glutamate. So what these two different medications do, the cholinesterase inhibitors can help improve a patient's ability to do activities of daily living, such as eating, bathing, dressing themselves, grooming, and so forth. They also help with memory and behaviors as well. Namenda is better known for also helping with memory, but also with language. And by language, I mean the ability to communicate what they want to say, to comprehend the information that's coming from other people, and just generally being able to carry out a conversation and so forth. So these treatments are to treat symptomatically the symptoms of Alzheimer's disease. They don't do anything for the two hallmarks, which I'm going to talk with you about, the plaques and tangles. And it's important to understand that these don't stop Alzheimer's, they don't cure it, they don't really slow the progression, but they can help some of the symptoms for a period of time. And that lack of information is usually missing when individuals go to see their primary care doctor, so they have unrealistic expectations, and they'll often stop these medications shortly after starting them. Other reasons that people frequently will stop is because they're costly, they're expensive, and the perceived lack of efficacy are the main ones. But they have benefits, although they are limited. We have an emerging view of Alzheimer's pathology that we have accumulated so much knowledge in the last couple of decades. 90% of what we know of Alzheimer's disease today, we've probably only learned in the last 15 years or so. So imagine all the advances that have happened just in the last couple of years, the funding that's starting to come in to help all the research efforts, how much there's still left for us to learn, and hopefully we'll find that out quite quickly. So on the left is a healthy brain cell. And you'll see it kind of looks like the root of a plant. And when you have all different kinds and numbers of brain cells in your brain together, they kind of look like the tips of trees reaching out to one another. And so a healthy brain cell, a signal like a message that one brain cell would need to send to another would go to the tip of that branch and shoot across it to the next brain cell, and that's called a synapse or a connection. And so for you to say, oh, I put my hand on something, it's very hot, I need to take it off, that would include limitless number of communications from the cells going back and forth to one another. But for an Alzheimer's patient, somewhere in between it might got missed, and so it's having to go a different route. And so sometimes you may find an Alzheimer's patient's able to remember something, it just takes a little bit longer. That message had a detour. So the one on the right, on the lower part, is the brain cell that's affected by Alzheimer's disease. There's two things I want to point out to you there. The green spots that you see are amyloid plaques, and those are made up of a protein called beta amyloid. Beta amyloid is a really sticky protein that develops, and these occur on the outside of a brain cell. If you imagine taking a piece of chewing gum and chewing it all up and taking it out and then stretching it, and then trying to throw pieces of candy through it, what you'll often find is the candy's going to get stuck in the wad of gum, and that's very similar to how they interfere with brain cells' ability to communicate with one another and to send those signals back and forth. The other pathology you'll see, and that's within the brain cell, those little red lines that make it look like somebody's got really bad red eye, those are neurofibrillary tangles, and that's made of another protein called tau. It rhymes with wow. And basically, tau disrupts these tracks that you have inside of your brain cell. Imagine them as railroad tracks. And nutrients are going up and down the brain cell to feed it, to allow it to survive and to do its function. These tau tangles are basically taking a sledgehammer and just going right through those train tracks and messing them up, so the nutrients aren't able to reach all the parts of the brain cell, and eventually it basically starves off and dies. So you have both of these pathologies happening at the same time in the brain of an Alzheimer's patient. And Dr. Morgan's going to be speaking a little later this afternoon, and he'll touch more on that. I just wanted to be sure that I presented enough information for you so that when I talk about the medications coming up, that you have a better understanding of those. So the medications I spoke about on the last slide, the cholinesterase inhibitors, the NMDA antagonists, those medications don't do anything for these two hallmarks of Alzheimer's disease, the plaques and the tangles. Next slide, please. So there's a number of treatments that we're currently researching, trying to find better ways to treat Alzheimer's disease, and it's a big race. All the pharmaceutical companies are trying to do their best to find all of these treatments, and there's been a number I'll discuss with you that have been tried and have failed, and some that are currently being researched. So the last 20 years of Alzheimer's research have focused almost exclusively on the amyloid plaques, and these medications, such as the one by Pfizer, bapineuzumab, that I'll speak about. Eli Lilly has a drug called solanezumab. Baxter had a drug called immunoglobulin therapy. Essentially, all of these were intravenous or IV administered medications, and they were done slightly different time frames. Sometimes they were once every 2 weeks, sometimes once a month, sometimes once every couple of months. But essentially, what they tried to do, they're passive immunotherapy approaches. They tried to get into the brain to use the body's own defense systems through their nervous system and their immune systems, bind to the amyloid plaque in the brain, and draw it out. Pfizer's bapineuzumab trials didn't find that it improved cognition in patients. Baxter's immunoglobulin, unfortunately, they found the same thing. But Eli Lilly is marching forward with their research efforts in solanezumab. The latest analysis of that particular drug showed it wasn't quite as aggressive as they had hoped, but it did slow the progression much more than treatments that are currently available. And I'm sure if I polled the room, all of you would say, I'll take something that does more than what's available currently today. Merck is also studying a drug, it's called a BACE inhibitor, and it's taking this disease by a different approach. So those drugs are trying to attack the plaques that are already made. Merck's BACE inhibitor is actually trying to stop the formation of further plaques by prohibiting a particular enzyme that comes along and snips a protein, and there's a couple of snips, and then that goes on to become beta amyloid, and plaques and so forth become formed, and it's trying to prohibit that. So as I mentioned, the last 20 years or so have focused primarily on these plaques. But a new company has come forward in the last couple of years. TauRx is a company out of Singapore that is pioneering something very new and very different. They're pioneering trying to find a medication that attacks the tangles in the brain that are caused by that tau protein. They had their first generation drug, which you may have heard of, is Rember, and they've come out with a second generation drug, which was Rember improved, called LMTX. I went to a meeting on this drug last fall, and it was really impressive. They're very spirited about what they hope this drug will do, but essentially, they believe that it can lower the amount of tau protein occurring in the brain, and it might also be able to dissolve the tangles that occur within the brain cells. And so I foresee someday there's probably a very good chance that the way you might take a cholinesterase inhibitor with an NMDA antagonist like Namenda, we'll probably take a medication that might help with the plaques, and we'll probably take another medication that helps with the tangles. But there's something very important to realize about these medications that we've learned in the last several years, and that is that we were testing in studies for mild to moderate Alzheimer's disease, and they were coming back unsuccessful. And as researchers, we truly believe that once the disease is in full swing, by the time you diagnose somebody, the pathology is in its fullest within the brain, and it's basically a snowball rolling down a hill. It would be very difficult to stop. So we're taking a step back and looking more at the mild Alzheimer's disease phase, or even the mild cognitive impairment phase. And now coming up, and I'm going to talk about it shortly, we're looking at prevention trials, trying to identify individuals who are at risk for that and pre-treating them, and I'll circle back to that shortly. While I'm still talking about research of treatments that's currently happening out in the lobby, a couple of you stopped and asked me if I'd be talking about coconut oil, so I wanted to touch on that briefly. So coconut oil came out in the last couple of years, and you may have seen there's been a lot of TV publicity and so forth about that being a treatment. There was a doctor here in Florida, Mary Newport, whose husband had Alzheimer's disease, and she treated him with a coconut oil product with medium chain triglycerides, and she saw significant improvement. And then as others caught on to this, they were coming forward with stories of how successful it was in helping their loved ones. Well, the truth is, and I'm not pessimistic by any means, when you're faced with such a crisis of Alzheimer's disease, we're all going to be very optimistic. And so as leaders in the industry of Alzheimer's disease and research, we were getting so many calls on a daily basis about people saying, does coconut oil really work? And to date, there was only anecdotal evidence to support that. We actually received private funding to conduct a clinical trial for coconut oil to see if it truly works and to put all the questions to rest. We're collecting validated data in a very organized, structured research protocol the way pharmaceutical companies do, and we look forward to having those results. That's still enrolling. The other thing that's coming up very soon is, it's actually currently rolling, NIH funded a study for a nasal insulin spray. And essentially, we truly believe that there's growing evidence that insulin carries out multiple functions in the brain, and that poor regulation of insulin could actually lead to the development of Alzheimer's disease. So NIH has funded this trial, and patients with mild cognitive impairment and mild Alzheimer's disease, again, they're trying to target groups earlier in the disease progression, would be treated with a nasal spray, something similar to like Flonase or something you might take for your sinuses. But both of these studies have one thing in common, in that they're trying to find an alternate fuel source for the brain. The brain, there's a number of neurological problems that affect the brain's ability to use glucose, Alzheimer's being one very significant one. That's why we're all here today. And these different treatments might provide a different fuel source for it to rely on. Coconut oil provides ketones. Ketones is something that your body generally has a very small store of, certainly not enough for your brain to rely on to do all its activity. But the coconut oil and medium chain triglycerides could flood your system with ketones, and the brain might be able to readily use that very actively and so forth. And the nasal spray helps regulate the insulin. So while these could be considered more of an acute treatment, something to address the problem more immediately. They don't, again, attack the plaques and tangles that we know are the two hallmarks of Alzheimer's disease, and so they may not be a very good long-term approach. Next slide, please. Here I have a graphic about what happens with Alzheimer's disease. Along the bottom, you'll see there's pre-symptomatic treatment, MCI, and dementia. And so as time goes on, you'll see very slowly the blue line, the one along the bottom, I guess that's more purple, it's kind of hard to tell up there. The purple line shows that as you go through time, memory loss creeps up, and then it's quite significant by the time dementia happens. Dr. Smith discussed the PET scans with you this morning, and the Amyvid PET scan. And what I'm sure she shared with you is that the pathology of amyloid plaque occurs long before memory loss actually occurs. And so you'll see when somebody's actually pre-symptomatic, they're starting to build those levels of amyloid plaque in their brains. And the National Institute on Aging is actually targeting a medication to pre-treat individuals who are at that phase. They're using individuals who are 65 and older, mainly because we have limited funding, and so we have to collect as much information as we can in a short period of time. Those who are 65 and older are at the highest risk for developing, but they're going to receive treatment with an amyloid targeting medication to see if we can actually prevent Alzheimer's disease. The baby boom generation started retiring at the traditional age of 65 in 2011, and every 67 seconds somebody develops Alzheimer's disease. Every day, 8,000 to 10,000 baby boomers are reaching retirement. So when you combine those statistics, the ability to actually try to prevent the disease, if it were successful, would be astronomical as far as the benefits. If we were able to delay the disease by a year, within 10 years, there would be a 7% reduction of Alzheimer's cases. If we were able to delay it just by 5 years, so perhaps not prevent it, but even delay the onset of the symptoms, within 10 years, we would see 40% reduction of Alzheimer's cases. And so I'm sure you can see the significance that that would have to you, to your loved ones, to families, on a more global scale, to health insurance, to Medicare, to our government, and so forth. The financial benefits would be very significant. And if I can have the next slide, please. Before I end, I want to talk about what happens in a clinical trial. I get questions all the time, and people say, well, I don't want to be a guinea pig. I'm so happy to tell you we generally don't use guinea pigs in Alzheimer's research. We typically use mice. So if you look, I've compared a patient who sees a doctor, and I compare a patient who's in a clinical trial. For example, mine, this one that I'm using statistics from is currently enrolling. And I showed you all the different procedures that you might get throughout a clinical trial. Now, to keep in mind, some of these procedures are safety procedures. We're keeping your best interest at mind as we conduct a clinical trial. So the one I'll point out, some of the significant ones, is you'll see lab work procedures. Somebody might have that done twice a year or even quarterly when they see their primary care doctor. For someone in my clinical trial, just within the first year, and keep in mind studies can be anywhere from several months long to a couple of years long. Within the first year, they've had it done 7 times. I can't tell you how often, through my lab work, not through their primary care doctors, I found that someone has a vitamin deficiency or is beginning to show signs of developing a urinary tract infection. And so the quality of care and the quantity of care, you can see, is generally much more significant. So that's a benefit in itself. But I'll point to the very bottom line. Besides the fact that you're getting access to a treatment that would otherwise not be available to you, and keep in mind, for us to find new research treatments for Alzheimer's disease, we have to conduct these trials. You'll see that the person who's going to their doctor, every time they go see that doctor, they have to pay. They have to pay a copay, their insurance has to pay, they may even have to pay out of pocket. But the person in the clinical trial, all of those costs, and again, they're getting them in much higher quantity and quite frankly quality, are free. The one other thing I'll point out is the cognitive evaluations. If you leave here today, know that you should see a memory specialist. Anytime that you have a health concern, the best thing that you can do is go to a specialist for that. If you had a strange rash, your dermatologist should say, I'll give you some cream to help the itching, but you really need to go see a dermatologist. And so a memory evaluation for a primary care doctor might be, tell me today's date and who's the president. Whereas when you're seeing a specialist, it's a very in-depth cognitive evaluation that will evaluate multiple parts of the brain, functions in the process of the Alzheimer's disease. So I hope you've gathered something from this discussion today. Alzheimer's disease research has come a long way, but we certainly have much farther to go, and certainly we would need your help. And I look forward to, in the next decade, if nothing else, trying to find ways to slow the disease progression and maybe even prevent it. Thank you.